Okay, so in today's meeting, what we're going to do is we're going to look at a systematic review, a recently published systematic review, and I'm going to explain how to interpret its finding, and specifically, uh, I think there's a spin in the conclusion of the research. What I mean by that is the conclusion of their research is not supported by the data or the results they've got. So this is the first segment of neurophysiotherapy update, where this segment focuses on decoding spin in research. This is part of our knowledge translation initiative. The objective is to help clinicians and students and researchers to understand what the research actually means, and more importantly, how research results can be translated to clinical practice. Right. So what I meant by spin or is interpretation bias is that sometimes authors often use a strategy, it's a reporting strategy, to make the study findings appear more favorable than what the results are actually suggesting. This happens especially when the results are suggesting negative or no difference. They do it deliberately or without knowing, but nevertheless, this has a major problem when it comes to clinicians when read this research and try to interpret it. And the spin can lead to misinterpretation of the findings, and which may eventually lead to coming to an incorrect conclusion. So when we are reading new research, whether it's a systematic review, RCT, or any other design, we need to be careful by not just getting carried away with the author's conclusion in the abstract or in the full text. Right. So this is the first question that we want to address. That is, what should we do when a new evidence is published that either support or not support the claims of benefits of an intervention? That is, a new research is published, it is showing that intervention is effective and it is improving, it is superior, author's conclusion are there. So when we come across a research like that, either systematic review or a randomized controlled trial, what should we assume, what conclusion that we can come to? In reality, what happens is when these research are either shared in social media or various social media platforms like Facebook, Twitter, and so on, or most of us tend to read the conclusion and decide that whether it supports our pre-existing beliefs or not. Then we start believing whatever the research results, that's conclusions say, and we tend to take it at the face value, that the conclusion says the treatment is effective, so therefore it is effective, and then it is being shared across, right? But what we should do, instead of immediately taking the results at face value and believing the author's conclusion, what should we do is first evaluate the quality of evidence, because quality of evidence only will determine whether their conclusion or the claims that they make is valid or not. Irrespective of whether it's an RCT or systematic review, if the quality of evidence is poor, then our confidence in their claim goes down drastically, depending upon how much quality is low. Once quality of evidence that we find is acceptable or good, then we move on to see whether the treatment effect is clinically worthwhile or not. What I mean by clinically worthwhile is in the difference or the effect that we see in an experimental treatment has to produce the effect that is our patients consider that is worthy of paying for the treatment. That is, if they take like 4 weeks of treatment, their pain or disability has to come down considerably. The word considerably is the contentious issue, but we need to see how much difference was there, whether we think the difference is clinically worthwhile, that is valuable, right? These two steps is what we need to do instead of just believing whatever the results are. Right? So how we are going to do this? Uh, we These are all the set of questions I suggest we should be looking at when we want to evaluate, that's quality and so on. First, I'm often not given adequate importance also, so I want to emphasize these four major questions. There are quite a few other questions. These are the four major questions I think we have to ask before coming to a conclusion about a value of an intervention which is reported in a systematic review or a randomized controlled trial. First thing we need to see is what was the comparator? What is the comparison against which a treatment is evaluated? Now, one might think that why does it matter? We want to see a treatment is superior, right? But it's not that simple, because if you're thinking from a clinical point of view, we are already giving a particular set of treatment for a problem. Mostly it may be some form of exercise therapy or electrotherapy. So for us to know that a newer treatment is more valuable than what we are already giving, then we need to see whether this newer treatment is compared with what we are already giving, that is conventional treatment, whether the comparator reflects the current practice. If it is not compared with current practice, then we cannot clearly say that it is worthy of us to change our treatment, because it needs to compare with what we are already doing. It needs to show that it is better than what we are doing. That is important. And in many studies, you will see the comparators are often placebo, sham treatment, no treatment, or they've given a treatment that doesn't reflect our practice. If that is true, then we can't really come to a conclusion whether is it worthy of adding another treatment. Next question we need to see whether the outcomes that they have seen is clinically relevant or not. The outcomes that they have measured. What I mean by clinically relevant is the outcomes that our patients are interested in. In a broader term, our patients are interested in pain, improvement in pain and disability. Pain is part of disability, but just for the sake of clarity, that disability at that level, that is their functional activity, they're not able to go to work, they're not able to do their daily function. These are all the outcomes that are considered clinically relevant. What are the outcomes that are not considered clinically relevant? Or impairment level outcomes, or some sort of what we call surrogate measures. Say, for example, range of motion, the joint angle, muscle strength, and quite a few, some sort of physiological measurements are not really what our patient wants to improve. Our patient wants to improve the more at a higher levels that has a direct relevance to them. Right? Thirdly, we need to ask what is the risk of bias. Now we need to have studies that has low risk of bias. Getting into what all different types of bias is entirely out of scope of this presentation, but I can tell you what happens. There's a high risk of bias. If the high risk of bias is there, then the effect that is estimated is likely to be overestimation. That is, in a study with a high risk of bias, if it shows that the pain is improved like 3 points, this is more likely to be the overestimation of the actual effect. Can you understand? Right? So we need to be careful, because if the risk of bias is more, then it is more likely to be overestimated. That means we don't really get we will not have much certainty on the effect size, right? And finally, is the difference clinically worthwhile? That's just the previous slide I've said. The difference that comes between what they have found with the new treatment has to be clinically worthwhile. That is, the difference should be large enough for our patients to consider, okay, this is really a good improvement, right? So with these questions, we are going to look at a recently published systematic review, getting quite a bit of popularity in certain circles in social media. This is published in 2nd of August, just a few days ago. It's a systematic review with a meta-analysis. It looked at efficacy of mobilization with movement for shoulder conditions. Mobilization with movement, as most of us know, is part of Mulligan's technique. And they found that, and the article abstract conclusion in the abstract, now this is what it states, is mobilization with movement is associated with improved pain, mobility, and function in patients with a range of shoulder musculoskeletal disorders, and the effects are clinically meaningful. Right? This is the conclusion in the abstract, and most people, most of us have the tendency or have only the time to read abstract. So this is what is given in abstract. However, these findings need to be interpreted with caution due to the high levels of heterogeneity and risk of bias. Now, this is a sort of disclaimer that they have had after that they have put across after they have explained. They stated that MWM is associated with improved pain. And as I was saying, there's a lot of interest in it, and people are saying, okay, the MWM showing so much of, it is so associated with improved pain, this is really good, and so on and so forth. Even though the last sentence, not much attention is given, and also it is not really clear what they actually mean by that. Okay, so if we see a abstract like this, what does the results actually mean? Does the result mean that MWM will lead to better outcomes, or should we use MWM for in shoulder pain, or should we use this systematic review as an evidence to support use of mobilization with movement? Okay. That's the question, and the abstract is conclusion is pretty much phrased in such a way to mean this, and this is the conclusion many people have come to by reading this. Many in the sense people whom I've seen in the social media, and also I think it is also the likely conclusion one can come after reading the abstract of the study or even the full text of the study. Right. So what we are going to do now, I think it's slightly okay. Let us first see. We will ask all these questions what I've just said initially. Before coming to conclusion, we need to ask these questions. So first thing, what were the comparators that are used in many studies reviewed in this systematic review? Most of the studies compared it with other manual therapy and also sham and no treatment, right? So we have just looked, I've just explained that the comparators are key because comparators has to reflect the conventional treatment. Now, conventional treatment for shoulder pain or related, whether it's any kind of shoulder pain, is exercises, electrotherapy, and some form of mobilization. The most common would be MITLAN. But in here, mobilization with movement is not compared against exercise therapy or with electrotherapy, a combination of these treatments. It is usually compared with isolated treatment of another mobilization or even with the sham and no treatment, right? So whatever effect that we are talking about, that the outcome is not, we cannot come to a conclusion because it is not against a conventional treatment that what we really gave. More importantly, which I'll come to it later, mobilization with movement is not given as a standalone treatment. In most of the studies, except to 2 studies, mobilization movement is given with exercise therapy, right? So, and it is not compared against exercise therapy, right? So when you have a mobilization movement given with exercise therapy and you compare it with other forms of mobilization and sham and no treatment, whatever effects that comes can be very well due to exercise therapy that is given and not necessarily the mobilization with movement. If they wanted to know what is the actual benefit of mobilization with movement into the exercise therapy, then that should be a comparison of exercise therapy with mobilization movement and mobilization with movement alone. Then one can claim. But in this review, most of the studies were not done to address a important question. It's all addressing questions that are clinically, in my view, are irrelevant. Okay, that's a bit. Okay, the next question is the outcomes they measured, are they relevant? Pain and disability, most scales, many studies are measured. Yes, it is relevant. Shoulder joint angle are not really relevant outcomes. That is in a sense that changes in shoulder mobility, that is joint angle, has to ultimately result in pain and disability. So when you measure pain and disability, that is all matters. Any change in range of motion without a consequent change in pain and disability is of irrelevant. So joint angle is not really a good. And we're just coming to the next question, another important question, that is whether the included studies or had low risk of bias. This is, as I've said, high risk of bias will show that overestimation of effect. But you can see in this overall systematic review, there's 25 studies are included, out of which 18 studies were rated as having high risk of bias. This is a rating given by the authors themselves, because I took all this information from the full text of the study. So 72% of the studies are having high risk of bias. And most of the studies did not have concealed allocation, blinded assessor, or a pre-published protocol, right? And they also rated that certainty of effect estimate. As I was saying, because there is a very high risk of bias, the effect estimate is very, very low for all 4 variables, that is shoulder abduction, shoulder flexion, range of motion, pain, and disability. These are the 4 outcomes we measured. So the effect estimate is very, very low. You can understand? So whatever effect size that come up with, that is the conclusion they have had, clinically meaningful, associated with improvement in pain and all of it, it is having high risk of bias, and the certainty is very, very low. So this is where the problem comes, which I think is a spin, that they should have used this statement in the abstract, that is effect estimate, there is a high risk of bias, I mean high risk of overestimation, rather than saying that caution should be applied, that because there is heterogeneity. That's really not a clear statement for readers. Right. Additionally, the quality of evidence was also rated with grade approach. Right. So what is the grade approach? Is an approach to rate the overall quality of evidence. So according to their own rating, it was rated as very low. That is the quality of evidence overall very low. Remember, the first 2 things I've said that we should evaluate before coming to a conclusion about a research: quality of evidence and effect size. Now, quality of evidence is very low. Now, again, what this very low actually means, interpretation as per grade approach, is that we have very little confidence in the effect estimate. The true effect is likely to be substantially different from the estimate of effect, which means whatever clinically worthwhile or pain improvement, whatever that they have said, it is more likely that we have very little confidence in it, and we may not get that kind of effect if we actually implement the treatment in our practice. Remember, this is the actual interpretation that is taken from the study, except that they didn't use this interpretation when concluding the review. And the grade approach also states that if quality of evidence is stated very low, that means this research does not provide a reliable indication of the likely effect, and the likelihood of that the effects would be substantially different is very high. This is what the actual interpretation of their study results. And in my view, this is what the conclusion should have been, rather than saying that it is associated with clinically improvement effect and all these things. Again, this is their own rating, except that they chose not to use this interpretation when they're coming to a conclusion, which I think they should have. Now, the fourth one, clinically worthwhile differences. Now, before coming to the step two, we need to be ensured that quality of evidence is good enough for us to look into the effect size. Because if the quality of evidence is not good enough, now whatever numbers they come up with is of less value, except in few circumstances where we are having no other options, no other alternates for treatment, but this is the only alternate, so somebody still want to take a risk with that, that is acceptable. But in this case, we already having better alternates such as exercise therapy and electrotherapy, if I can add. It is having, so this this intervention, or that is MWM, doesn't really add much to it. So one would really want to, I would say that it is really not that much important now to look into. Right, it's really not important to look into the result, because these estimates are likely to be overestimate because of the risk of bias, and is based upon their own interpretation of it. And but I would just, for the technicality purpose, I would still want to show you what they have found. There are two tables that is giving. One is for frozen shoulder pain, the other is for any kind of shoulder pain other than frozen shoulder pain. They have pain, disability, abduction, range of motion. Let us look at pain, abduction and flexion, because it is given in mean difference, which is easy to interpret. That is 13 degrees and 11 degrees improvement is what we get. And again, I would like to bring your attention to the confidence interval, which is more important, because confidence interval is the estimate of effect in a population. That is, in our patient, what we are likely to get. It may range from 6 degrees to 90 degrees, and the flexion may range from 5 degrees to 17 degrees. And anyone with a decent understanding of clinical context would know that this improvement in range of motion is no big deal. But again, this effect estimate can be very low because it is having a high risk of bias. As is for pain and disability. Pain and disability is indicated with a standardized mean difference. It's slightly recalculated one, because they've used different types of outcome measures to pain and disability. And 1.23 on 1.5 is what we call, it's an acceptable one, even though there are a lot of issues with there. But you can see again, the lower estimate is very low, 0.5 and 0.7, right? And the risk of bias is rated for all these studies is very serious. So even though for pain and disability, the SMD falls in an acceptable range, but again, without having to convert this into a clinically meaningful term, but if we just have to go with technicality, it shows that it's acceptable. But having with a very high, serious risk of bias, the interpretation is it is likely to be a overestimate of actual numbers. This is the another table with for shoulder pain and movement dysfunction subcategory. The results are more or less similar for this also. Okay, so in addition to all these concerns about risk of bias and not having clinically worthwhile improvement, I have also noted few other major concerns. One of the major concern, as I've already said, is that all studies except two on that MWM is combined with exercise therapy and or electrotherapy. That means exercise therapy is not ever, I mean, I'm sorry, mobilization with movement is not evaluated as a standalone treatment. So whatever effect that we have got, we cannot individually attribute it to MWM. Remember, if you look at the abstract conclusion, they did not add that they stated as if it is effect of MWM, right? And the clinical meaningful difference, they did not define what they expected to be clinically meaningful difference, even though they added the word in conclusion that it's clinically worthwhile, but they didn't really say what was their definition of clinically meaningful. And another major issue which I found is that most of the articles that they've included in the review are published in non-indexed and predatory journals. This is a serious concern. Usually in a systematic review, we don't find much of non-indexed predatory journals being included, but this has majority of articles that are included are published in predatory journals. And out of all the RCTs, only 6 studies were registered. That means the possibilities of protocol violation, we are not in a position to actually identify. Right? So these, keeping all this in mind, whether we can accept, conclusion that it's clinically meaningful with this very high risk of bias that basically says that what the meaning of very high risk means there is very little confidence in effect estimate. So what the conclusion should have been that the available evidence does not allow us to make a conclusion about effectiveness of this treatment because there are a very high risk of bias. So until RCTs with low risk of bias and sufficient word studies are done, we cannot conclude that it is actually beneficial. That is what the results are actually suggesting, but the abstract results doesn't really give us an impression that it was very put in a very positive way, even though they added that needs to be interpreted with caution, but they didn't really say what that actually means. I think they should have simply stated the high risk of bias or a very low quality, what it means in a grade approach. It is clearly defined, which is also included in one of the table, but they did not use that interpretation when they come to a conclusion of this systematic review. Okay, so that is all I have for this presentation. You can ask if you're having any questions, you can ask now.